Good afternoon. Can you hear me well? Yes? Okay. Hi there. Welcome to the second of the series of CT and data science webinars. And I was told that I should remind you that this session is being recorded. So it's my pleasure to introduce Dr. Lisa Marsch, who is the Director of the Center for Technology and Behavioral Health at Dartmouth College. She's also the Director of the Dartmouth Psychiatric Research Center and the Andrew Wallace Professor of Psychiatry in the Geisel School of Medicine at Dartmouth College. Dr. Marsch's Center for Technology and Behavioral Health is a P30 that is supported by the National Institute on Drug Abuse, and it's composed of an interdisciplinary research and development group focused on the systematic application of cutting-edge technologies to the delivery of behavior change interventions for individuals with substance use disorders and other behavioral health issues. So Dr. Marsch is here to tell us about the state of the science for the use of technology in the management of substance use disorders in various healthcare settings, and also to share with us her thoughts about the implications and next steps for research in this arena. So with that, I welcome Dr. Lisa Marsch.
Most importantly, she is a CTN node PI.
I failed to mention the obvious.
Thanks so much, Geetha and Betty, for this invitation to speak here today at NIDA, and I'm so pleased to have the chance to have this broadcast to the broad clinical trials network community across the country, and we are so thrilled, as Betty mentioned, to just have been recently funded as a new node of the National CTN. Ours is the Northeast node, and we have a terrific array of partners in the states of Maine and Vermont and New Hampshire, and we're just so pleased to join in this terrific research infrastructure platform. So today, I'm going to talk to you about the state of the science of harnessing technology as applied to substance use disorders. And I'd like to give you sort of a big picture overview of how technology can be useful in the full spectrum of screening and prevention and treatment and recovery support and care coordination for substance use disorders, and describe a bit about the patterns of findings we're seeing in the research realm in this space. But I'd like to do so with an eye toward some opportunities for the Clinical Trials Network to consider in this next iteration of the CTN, and thinking about integrated care, thinking about new models of increasing reach and impact of treatment of substance use disorders, and to consider how can we better harness technology in some of this research. So that's where I'd like to end up, and we're watching the clock here, and so at the end of the presentation we'll unmute the lines and ensure that there's some time for discussion. So first, I have to, of course, thank NIDA for such terrific research support, not only for our Center for Technology and Behavioral Health, which Geetha described, which is a NIDA-funded P30 center, and I'll describe that center a bit more toward the end of this talk, but also for our new NIDA CTN award to be part of this National Clinical Trials Network platform, and several other research grants that I'll be mentioning today when I show you some data slides. I also want to acknowledge that in addition to my academic affiliation at Dartmouth College, I'm affiliated with two small businesses that are involved in deploying technology-based behavioral health tools, HealthSim and Square 2 Systems. And this is part of our effort to have some important academic industry partnerships to ensure that we can help disseminate tools that are evidence-based. So when you think about technology, it has transformed virtually every aspect of our society, right? We do our finances online, we arrange our travel online, we buy things online, we have social relationships online, people meet their significant others online. I mean, it's transformed so much of how we live our daily lives. And what I would suggest to you from a very large and growing body of data that similarly, I think that technology can have a transformative impact in how we deliver health care, in increasing the reach, the quality, and the personalization of care while reducing costs. And I will show you data to support these statements, but I think we're on the verge of something rather striking in terms of technology-assisted service delivery models in the health space broadly, including in the work that we do in behavioral health around substance use and related issues. And these applications of technologies, mobile and web-based tools, can not only apply to clinical populations like folks with substance use disorders or folks with mental health challenges, but also we see an explosion of interest with folks monitoring all kinds of aspects of their behavior and activities, their sleep cycles, their medication taking, their sort of activity levels. And so there's a growing movement to increase self-knowledge via new levels, sort of unprecedented models of data capture, which some people call the quantified self movement. So when you think about the application of technology to behavioral health, I think that there are many creative ways that we can think about this through the entire spectrum, from assessment and screening to prevention, to treatment, to recovery support, to care coordination for substance use disorders. And on this slide, we've listed just a few examples of the many ways that you can creatively think about this, including, first of all, in the assessment space. And we know that, for example, if you capture data about people on mobile devices as they move through their daily lives, you get richer data, you get more standardized data, you get more accurate data about their functioning, about their health state, than you do, let's say, if you ask them to recall last 30 days about these things. And we heard a terrific presentation at our last webinar series by Kenzie Preston, who's at the NIDA Intramural Center, who's been doing some real pioneering work in this space. In the intervention space, there are lots of applications with a growing body of data to support their utility, including prevention interventions, tools that can be used for youth, for example, building up protective factors and reducing risk factors for substance use and other risk behavior among children and adolescents. Lots of opportunities in the behavior therapy space for providing self-learning, self-management tools, skills training types of tools that can help people in identifying personal goals, track progress toward goals, help in initiating and maintaining behavior change, including around problematic substance use, for example. And also these can be coupled with or be part of a suite of tools that embrace sensors. There's a very exciting field of sensing, wearable sensors, as well as using sensors embedded on mobile devices to capture data that can enhance our understanding of health behavior and interventions to target health behavior. Your smartphone, for example, has extraordinary computational capacity and has all kinds of sensors embedded in it, including, your activity levels, your sleep cycles, tracking your location. You can track paralinguistic aspects of people's speech, which can predict things like their sociability or their depression levels. So there's lots of opportunity for rich data collection, which may not always rely on user input, but can have some passive data collection that can increase our understanding of behavior and behavior change. And these tools may not always just be for individuals or consumers or patients, but may also engage an extended support network, which may, of course, include clinicians when offered in the context of a healthcare system, but don't have to. I think this is a point we should talk about a bit today, is the opportunity to leverage these tools both within and outside of our healthcare systems to engage individuals, but also extended support networks of their choosing, which may leverage things like social media, for example, in creative ways, to have folks supporting them in initiating and maintaining health behavior change that's aligned with individual goals and values. And you can embrace incentive systems, what we know about how you can reinforce behavior change in the context of social media using principles of gamification, for example. So lots of opportunity to engage consumers and a care network of their choosing in sort of unprecedented ways with technology. So here are some potential benefits of thinking about technology as part of the way in which we offer healthcare services. One, of course, is the reach potential, the opportunity to have widespread dissemination of evidence-based intervention. So really pushing out in a widespread, scalable way resources that can help people meeting personal goals. And can do so in a way that ensures quality, right? We know that we can deliver care with fidelity. We can do it in a way that's wedded to science of how we can best promote behavior change. And there's really unprecedented levels of personalization that this affords. So if we think that it's critical to personalize on cultural factors or on cognitive functioning types of variables or other areas of people's needs and preferences, we can have systems that flexibly respond to these different issues. And as I mentioned earlier, this issue of engagement is, this idea that, even most of the world is increasingly getting access to mobile devices. And so it's really a new way to have patient empowerment or patient engagement in new ways where people can play leading roles in their own care management, which is very different than our traditional models of healthcare. So another potential benefit of this is something called Justintine Care. So this is a term you may have heard, this idea of having 24/7 access to therapeutic support via electronic devices, available anytime, anywhere. So if you're feeling at risk for, drug use on a weekend in the late hours of the night, or if you're feeling a mental health crisis, for example, at that time, you may not have someone you can talk to in a traditional healthcare system, but you may have a resource in your home that can be available to you at that moment to help you manage that successfully and to help prevent costly escalation of these problems. And indeed, there's some growing data that suggests that when you use tools in this way, you can indeed avert some costly problems that could ensue. There's also a growing area of research around how technology can help us in addressing healthcare disparities. So we know that that we still continue to have barriers in access to care and disparities in access to care in some of our traditional models of care with certain populations, with certain settings such as rural locations. And yet, I'll show you some data around this, but we know that even the most traditionally vulnerable and disadvantaged populations around the world really are either have access or are getting access at fast, quickly growing rates to technology tools that can provide resources to them. And so really an opportunity to think about how this can help with addressing disparities in access. We also work with healthcare systems that have been interested in using technology to increase service capacity. So in a system where you have a limited number of dollars, a limited number of clinician resources, by embedding technology as part of the service delivery model, you may be able to treat a large number of patients. So seeing more people with the same number of clinician resources. And I'll show you some data from some examples of some NIDA-funded studies where we've looked at this. So I'm not suggesting that technology is a solution to all of our challenges in this space, but I do think that the data are from the last 15 or more years now are very clear that if these types of tools are developed well, they can have a striking impact on all kinds of populations and all kinds of contexts. And I think there's a very exciting public health significance to this work. And if we were to scale this up, that we could have a population level impact. So this slide underscores the point I made earlier that access to the internet and mobile devices is growing at extraordinary rates. And so currently about 90% of the world's population has access to mobile services, and that's just under 7 billion mobile phone subscriptions worldwide. And many of these phones are smartphones, and smartphone access is also growing at exponential rates. It's expected to triple globally by 2019 to just under 6 billion. And smartphones, again, I mean, the computational capacity of these tools is just really extraordinary, and in terms of the sensing abilities, in terms of being able to access the internet and all the resources that it allows. And so even some of the most disadvantaged groups we work with, chronic homeless drug users or people with active psychotic disorders who are substance users, we find that these folks have access to these devices. And so it's just an exciting opportunity to think about how can we harness the ubiquity of these tools in the work that we do. So this slide highlights a pattern of findings that we've seen in this space broadly. This is sort of a summary of about 15 years of research on this slide, which indicates that if you develop these technology tools well, and the development is really key. We could talk at length about development and how you can develop tools that work and how you can develop tools that don't work. But if indeed you have a resource that brings meaning, brings value, has utility to your target population, you can find that you can get high usefulness and acceptability to very broad populations, from children to aging populations to all kinds of different clinical populations. You can have a large impact on health behavior and health outcomes, again, across lots of different areas of behavior and health outcomes. And we've seen in several areas of research now that the outcomes you can achieve with technology-based tools can be comparable to or sometimes better than what you get with clinician-delivered therapy. And so some people might feel like that's alarming, and we're trying to replace clinicians with technology tools, but it's very important, I think, to understand that these tools have active ingredients that can actually be effective. And we know that there aren't enough clinicians to address the entirety of substance use challenges or behavioral health challenges broadly. And so these are tools that can add value to the behavioral health workforce. And can do so, again, in a way that increases quality, reach, and personalization of care. There's some growing evidence of cost effectiveness of these tools when used in different contexts. And I think what's also exciting is that these tools don't have to be static. It doesn't have to be, this is a 12-session behavioral therapy that always works the same way. We know that people's needs and preferences and clinical trajectories change over time, and you can have tools that adapt to those changing needs and preferences over time and are responsive to where the individual is and what their goals and values are. Okay, so these stats are very familiar probably to this audience, but what we know is that mental health and substance use disorders are very common in their own regard and significant in their own regard. We know that about 1 in 4 to about 1 in 5 adults are diagnosable with 1 or more mental health disorders, and about 1 in 10 are diagnosable with 1 or more substance use disorders. And this audience knows well that folks who have these challenges are among the most frequent and the costliest utilizers of our healthcare system, right? So we know that the overall annual economic cost of mental health disorders, for example, is estimated at over $300 billion, and the cost has been going up in recent years. And the World Health Organization, for example, estimates that mental illness accounts for more disability in developed countries than many other groups of illnesses, including things like cancer, for example. So folks who may not work in this space often find it really striking that things like cancer and heart disease account for less disability than mental health. So we know that these things are quite significant and costly, but we also know that substance use disorders and mental health challenges are also highly prevalent among many clinical populations, right, including folks with chronic physical health conditions, which includes a lot of the American population and accounts for over 75% of our healthcare costs. So a significant issue that we're managing. And so here's one example. We know that persons with diabetes have about 40 to 72% incidence of depression and 50% co-occurring incidence of anxiety. So these things are clustering together. And what we also know is that when substance use and mental health problems cluster with chronic physical health problems, cost of care is higher and the outcomes are worse, right? So we know we have lower quality of life, poorer response to treatment, worse medical and psychiatric outcomes, higher mortality, higher cost of care when these things co-occur versus when they do not. And so again, back to this example of depression and diabetes, when these co-occur, healthcare costs increase by 50 to 75% versus when they're not clustered together. So I mention this because, I think that sometimes we work in specialized areas of substance use or mental health, but these issues impact the full spectrum of health and wellness, not only in terms of the clinical course, but the cost of care. And so there's a terrifically important opportunity to think about health broadly and how substance use fits into that larger equation. And we know certainly that that there's been, for some time now, changing healthcare legislation in this country that has indeed incentivized integrated models of care where we don't think about addiction and substance use treatment so much as just being offered in specialty siloed programs, but also embedding it into healthcare systems broadly, general medical systems broadly. And what we also know, unfortunately, is that there is a limited workforce that can sufficiently address this need. So do we have enough addiction specialists and mental health specialists to fully screen for and provide interventions and resources to people who have these problems in primary care, for example? And I think that we know the answer is that we don't. And so this, I think, is one very promising area for us to insert empirically supported technology tools and systems that can help facilitate the integration of care in addressing this sort of health spectrum broadly and how substance use intersects with it. So there are many different ways you can think about the use of technology. A healthcare system could added on to their existing service delivery model as a supplement to what they do, a supplement to medication-assisted treatment, a supplement to clinician-delivered therapy, for example. And when it's offered in that way, sometimes it's called a clinician extender model. So it's another tool or set of tools in the toolbox of your clinicians that can extend the reach and the impact of the work that they're doing with their patient base. So that's one way you can think about it. But there are many ways that you can think about it, including a model where you actually replace a portion of a typical client-patient interaction with a technology-delivered intervention. So why would you want to do that? Well, as I mentioned earlier, some healthcare systems are very keen to do this because then they can see more people this way. If they have a technology system to which they offload some of their care delivery, then with their clinician base, they can see more patients. Or they could free up their clinicians perhaps to have more time to deal with people who have crises or have more significant needs. For example, we work in different types of settings, including especially addiction treatment programs, where the counselor might have 50 people on their caseload, and they have an obligation of making sure that they see each of those folks with a certain frequency. And we know that people have crises and have more need, and that there's just not time for that. So if you had a model where you integrate technology into the service delivery model, that may be useful for allowing clinicians to really work more with clients who have more intensive care needs. And a different model altogether is to think about these as standalone tools. We don't have to think about these as entirely offered within our healthcare system. They can bring great value there, but I think they can bring great value outside of our healthcare system, direct-to-consumer kinds of approaches. Maybe this would be helpful in rural settings where people can't access care. But what we also know is a lot of people don't want to go to our care models. They don't want to go to highly stigmatized specialty care systems, for example. And we know that 90% of folks in the U.S. who have substance use or mental health problems do not go to our existing treatment programs for these problems. So we're touching 10%, and this is an extraordinary opportunity to think creatively about how do we reach this 90%, the majority of the population, in new ways. And again, given that folks live in the world of social media and live with mobile devices, this is one of the opportunities that we have before us, I think, to address this. So what I'd like to do now is show you some data, and I'm going to show you data to illustrate some of these models of deployment and the kinds of outcomes that you can get from these types of approaches. But I'd like to then go from there to talk about where we can go in this field of research and application. When I show you data, I'm going to show you data from one specific system called the Therapeutic Education System. And this is one of several systems that have been developed for addressing substance use and mental health issues. And this is one that was, the first version of it was developed many years ago now, so it's been used in many different clinical trials and other types of research projects. And so I use this as an example because you can see when you deploy it in different ways what kinds of patterns of findings you can get with this tool. So this is a system that many in the CTN community may know well because it was also used in a prior CTN multi-site trial. It's an interactive behavioral therapy. I'm not going to talk in great detail about it because it's really just an exemplar of an approach in this space. But briefly, it's an interactive digital therapy, really, that's grounded in an evidence-based model of behavior therapy called community reinforcement approach, which includes a broad focus on skills training, but also a broad focus on helping people restructure their lifestyles and their patterns of behavior to start doing things they enjoy that are consistent with their goals and values that don't involve drug use. But it includes some of the topics listed here. How do you solve problems? How do you cope effectively? How do you communicate effectively? How do you make good decisions? How do you manage negative moods, etc.? So this evidence-based behavior therapy is wedded to certain informational technologies that have been shown to be effective in teaching skills and information to people and promoting long-term retention of those things. And it's a web-based program available on different platforms, both desktop computer, but also smartphones, iPhones, iPads, etc. And these are just some screenshots. Again, I'm not going to go into a lot of detail. There are 65 different sections in the system, lots of interactive exercises, lots of psychoeducational skills training content, lots of tools that people can use in helping them change problematic substance use. So I'm gonna just briefly describe maybe about 4 or 5 different studies that have used this tool in different models of implementation, okay, and show you the kinds of patterns of findings you can get in this space, and then talk about where we might consider going from here in this area broadly. Big picture from this particular field of research has shown that when this therapeutic education system replaces clinician-delivered behavior therapy, you get outcomes that are as effective as evidence-based behavior therapy delivered by therapists. But when you partially substitute for standard counseling or add it as a supplement to standard community-based counseling that you get in many addiction treatment programs in this country, we actually get better outcomes. And some of the findings show as much as doubling abstinence rates from drugs of abuse when this is part of the care model versus when it is not. So let me show you some examples. The first one is an efficacy trial. So this is a tightly controlled study that was done in a research setting where 135 opioid-dependent adults came in for outpatient treatment. Every one of these folks received Suboxone medication, so they all received buprenorphine medication for stabilizing their opioid addiction. But what differed here is the nature of the behavior therapy that they received along with the medication. So they were randomly assigned to 1 of 3 conditions. The folks who went into the arm that's reflected in blue on the graph received individual therapy sessions with a counselor who was highly trained in this evidence-based community reinforcement approach to behavior therapy. 3 times a week they met with that counselor, okay, one-on-one sessions. Folks who went into the red arm still had a counselor, but they only saw that counselor 1 out of every 6 sessions, and 5 out of every 6 sessions they worked on one-on-one in a computer lab at the site on this technology platform. Okay, and then those who went to the third arm in the gray here reflected standard counseling that you get in many addiction treatment programs for opioid dependence around the U.S., which was not wedded to this evidence-based behavior therapy model. So the point here is that we saw that when you receive the therapist version exclusively or the computer-assisted version of this evidence-based behavior therapy, we had comparable reductions in drug use, in this case opioids and cocaine, objectively measured with urine testing in this case, despite having in one arm, reduced patient-clinician contact time by 80%, okay? And both of those produce better outcomes than standard counseling. So this is an example of a partial replacement model where you've dramatically reduced clinician-patient contact time in a way that has retained the effectiveness of the approach. But again, there are implications in terms of, well, what does that mean? Because the clinicians then have a larger patient base and pull people off wait lists, for example, for these programs. So there's one example. This is a different example, which is an effectiveness trial that was done in real world. This was done in methadone treatment settings, 160 patients coming in as new intakes into methadone treatment for opioid dependence were monitored for 12 months after having been randomly assigned to 1 of 2 study conditions. The first was in the blue, treatment as usual, which is outpatient methadone treatment, receiving this medication daily, and having the counselor that they need at the site. Or they went into a model where they had a reduction in treatment as usual, which was replaced with this interactive web-based tool. So they still had a counselor, but instead of meeting with them for 60 minutes, they would meet with them for 30, and then the other 30 they would go to the computer lab, okay? And what we found is that when you cut in half the clinician-patient contact time and replace it with this interactive personalized tool, we had higher rates of objectively measured opioid abstinence compared to when that's not part of the care model. Okay, so we have this behavioral therapy that is personalized, it's interactive, that's responsive to where people are in their understanding of behavior change, that they can use one-on-one, that when that's offered, you can get better outcomes than our traditional models of care. And there was a terrifically rigorous trial run on the CTN platform that Ned Nunez and Amy Campbell led with partners around the country with a much broader population of folks who were involved in all kinds of different areas of substance use, stimulant use, cannabis, alcohol, et cetera. And the design was somewhat similar. There were some differences to it. It included incentives in that study for use of the tool and for negative urines. But the pattern of results was not unlike what I'm showing you here for this opioid-dependent sample. So again, this is an illustration of the kinds of outcomes that you can get with a partial replacement model in a real-world clinic. I think we're going to save the questions to the end. Okay. So we've been looking a lot at mediators of effect and moderators of effect. You know, question comes up as well. Overall, it looks like there's an advantage to having this tool, but does it really work for all the different subpopulations in your sample? You know, what about the people who are in and out the door of addiction treatment programs? Is it really going to help those people, for example? So we've been engaged in a number of different studies looking at this, and what we found from this trial, for example, is that people who come in with these types of characteristics, low cognitive functioning or high anxiety, or high ambivalence about changing drug use in treatment, or people who had co-occurring heavy alcohol use along with their opiate use, or people who had a greater number of prior treatment episodes when they came to this program. What we actually saw is that those subpopulations actually had better outcomes when the web-based tool was part of the care model versus if they went into standard treatment. So we had better abstinence rates, we had better retention for those groups when this was part of the service delivery model, which is interesting because, you know, there's now probably 3 or 4 papers that suggest that technology-based tools that people can use, you know, in a way that's responsive to their needs and their goals may be useful in minimizing the impact of some risk factors on treatment outcomes. So this is an interesting area of research I think that we need to better understand. I'll just briefly describe this to show you a different model of deployment of technology tools. And this was the delivery of a technology system as the only system of care. So there's no clinician involved. It's a standalone model. Okay, so this was a trial comparing prisoners, male and female inmates who were in prisons around 4 sites around the country. And they were randomly assigned to either receive exclusively this web-based intervention or exclusively clinician-delivered care. Okay, so in this context, why might this design be important? Well, we know that prisoners have, many of them have substance involvement before being incarcerated, as high as 80% roughly. And we know that the resources in many criminal justice systems are very limited in addressing even the most basic drug education among many of these folks. Some of our partner sites had rules where people couldn't be eligible for parole until they went to a group counseling intervention for their drug use. And there were wait lists to get on this. Sometimes people's parole was delayed because they're still on the wait list for this thing that's required for their parole. So there's a real workforce limitation and the need is high. And so the idea is scalability. How do we address this in a way that's scalable? And the question here was, if all we've got is a technology system in this setting where the need is great, what is its relative effectiveness compared to a clinician-delivered version, clinician-delivered intervention for drug addiction? So this was a NIDA-funded trial. This was a prospective longitudinal study where folks who joined the study joined while they were incarcerated, but we looked at outcomes post-prison release. So what happened 3 and 6 and actually 12 months post-prison release. And just briefly, what we found is that drug use rates were high at baseline, both among those who went into, in blue here, those who went into the computerized intervention, as well as those who went into the clinician-delivered intervention in orange. And both groups had comparable reductions in drug use at 3 and 6 months post-prison release. So it didn't matter if they went to a computer lab when they were in prison and worked on the web-based system versus if they went to a group session. The outcomes were not dissimilar on many measures, including criminal activity measured with arrest data, self-report data, reincarceration data, and we have a similar pattern for HIV risk behavior. So I highlight this study as an example of a context in which a standalone technology-based therapeutic tool may be of value. So I think that in different settings, there are different clinical considerations that may drive how you leverage these tools. Okay, and one more, I think, example that I'll briefly mention. This was a small study. We have a much larger 3-arm trial going on now, but this was a small study where folks coming into outpatient addiction treatment received either standard addiction treatment or they got access to a mobile version of this a part of the psychosocial treatment that I'm describing to you. So new intakes coming in, go into standard treatment, or have a mobile version of this available to you as part of your treatment. And we looked at what happened for the first 12 weeks of this new treatment episode. Okay, and what we found is that people generally use the phone and the tools on the phone, and we had high ratings of acceptability and feasibility of this. And we have lots of rich qualitative data describing how people used it and often using it to prepare for what they think might be high-risk times and how can they strategize to be successful in not using. So very rich qualitative data, but also very interesting quantitative data showing that, in this case, the percent of participants who were retained in treatment, in the treatment program, when they did versus did not get access to this tool was very striking. So we had 84% of those who got this simple tool as part of the care model retained in treatment versus 56% who didn't. And so, you know, it's a simple sort of tool that's an adjunct, a supplement to what you're already doing, and it can have a striking impact on retention. Again, we're seeing if we replicate this in a larger sample, but this was very promising, and especially because we know that treatment retention is such an important predictor of longer-term outcomes. This same pattern showed up in urine tests. So we had more negative urine for opioids when you got this tool versus when you didn't as part of the care model. So I highlight this as an example of the kinds of outcomes you can get when this is a supplement, a clinician extender kind of model to what you're already doing in a treatment system. So I wanted to illustrate different kinds of models of deployment with that one tool, but there are some really, if you look at the landscape of what you see out there from very careful, rigorous development and research in this space, there are lots of similar striking patterns. So for example, with NIDA support, we recently finished a study where we used a version of this system for patients with chronic pain who have aberrant opioid-taking behavior, okay, in managing their chronic pain. And what we offered them was a web-based tool as a supplement to what they were getting in pain specialty programs, right? So they're getting, you know, medications, they're getting opioids, they're getting surgical and medical interventions. But we gave them access to a mobile version of a chronic pain management program. How do you effectively manage your pain? How do you do so in a way that meets your goals, et cetera? When you offer this tool as part of the care model, what we found is that we actually changed aberrant opioid taking behavior. We reduced the aberrant opioid use, and we also saw that we reduced utilization of the emergency room for pain when you got this along with the care versus when you didn't. So this could translate into some pretty striking cost savings given how we know how costly ER utilization is. So that's another sort of related finding to this broader space of substance use-related issues like chronic pain. HIV is another one, and we know from a couple of different NIDA-funded trials now that web-based HIV prevention tools can reduce HIV risk behavior as well as comparable clinician-centered care. We know that trauma, providing mobile resources for vets with trauma and substance use can reduce their substance use, and can do it in a way that you don't have to talk about the stigmatizing behavior in the context of in the context of your commanding officer and in sort of in the VA system, where people really don't often want to do that, particularly when it's an illegal drug use. And so so this is something that we did in primary care. We also know that web-based games for kids, multimedia games for kids that are wedded to prevention science can be as effective as gold standard prevention programming that's delivered by highly trained educators. Again, we don't have enough specialists to do this in a way that's scalable, and so there's an opportunity to think about leveraging some of these tools to help promote more widespread access in a way that can actually produce effects reliably. Okay, so what I'd like to do now, and I'll surely save time for some discussion at the end, but I'd like to just talk a little bit about opportunities in this space. I mean, I've had the privilege of working with a very diverse, interdisciplinary group of partners in our Center for Technology and Behavioral Health, from people who specialize in addictions and behavior change, but also in areas like emerging technologies and ubiquitous computing and data analytics and implementation research and mobile research ethics and sort of this whole spectrum. And we've had the chance now to work with lots of different populations in lots of different contexts. And it's very striking, the patterns of results you see across this landscape and how there are some tools and resources that really can affect change in a way that's sort of independent of population and that can really transcend context. And I think that there's a lot of learning, particularly from very rigorous NIH-supported research, that can be integrated in a way that we can scale up the science of this in a way that can actually work to transform the way we deliver healthcare, both within as well as outside of healthcare systems. So one real important, I think, timely opportunity for us is to consider how we can centrally use technology to facilitate integrated substance use and general medical care. As we talked about earlier, there's a growing demand for this, there's a need for this, huge benefits of this when we think about not just this one aspect of the individual, but how it relates to their health broadly. There's healthcare systems, there's legislation that incentivizes this. And I think we have a very rich resource base research base to build from, to scale up this learning, to take it outside of single-site RCTs, to actually test new models of service delivery that, again, embed technology systems or tools in an integrated care model. Again, we don't have a sufficient behavioral health workforce to take this on, and this is a way to do this in a way that can be scalable but ensure quality and cost effectiveness. And so in doing that, it's of course critical for us to look at patient outcomes, and I've shown you many examples of the kinds of outcomes you can get at the patient level. But there's, I think, a really important opportunity to think about a comprehensive focus on not only the service delivery model, but also the accompanying payment model, right? So it's not just, it's the organizational factors, it's what's going to fit into workflow, what's going to add value and not burden, what's going to do so in a way that translates into cost effectiveness, maybe realizing savings not only on addiction treatment or behavioral health expenditures, but also general medical expenditures when we address this very significant issue of substance use. So I really think there's an opportunity to think about all the relevant stakeholders and really an interdisciplinary group that can come to the conceptualization and the implementation of a project like this, so that we're really anticipating what's going to make sense in the organizational and the regulatory context in which we do this work in a way that can be sustainable. I think we have enough data from lots of individual R01s and lots of work in this space that collectively we're ready to inform something like this. The other opportunity I think that's really, I think, very important for us to think about is to break down siloed disorder-specific approaches to addressing to developing and deploying these technology health-based tools. So if you look around you, right, this is an app for managing depression. That one's for managing your medication taking. This one's for anxiety. That one's for drug use. This one's for your hypertension. You know, so there are all these siloed apps, and I think we have many providers, you know, clinicians that are trained in very specialized areas of medicine. And I think we've replicated some of that siloed work in the way we've developed technology tools. But we don't have to. Right? We don't have to do that. We know that we can create systems that can be flexibly adaptive to whatever combination of needs and preferences people present with for treatment, right? Maybe it's drug use, and maybe it's, you know, depression or hypertension or other challenges people may have in medical regimen adherence for chronic physical health conditions. And we don't have to mimic siloed nature of healthcare service delivery in the way we develop these systems. We can have tools that embed the fundamental principles of the science of behavior change and have some core common functionality for end users, but then have different paths and different types of resources and functionality that can be brought in a way that's directly responsive to people's goals and values and needs and clinical priorities. And this, to me, is very exciting because, again, we know that these different clinical considerations interact in very important ways that translate into clinical outcomes, that translate into costs. And so if we're really going to think about transformative healthcare systems, I think one way to do that is to really think about a person as a whole. And drug use, of course, intersects in a very significant way in that, but it's part of a much bigger picture. And so this is something that, as we think about integrated care, yes, we can think about embedding a technology-based intervention for substance use into primary care, but why don't we think about, the person in primary care more broadly, and what is their sort of profile of needs and preferences, and how drug use intersects with that, and provide resources that are responsive to that. So this, to me, is very exciting. We've been working very extensively on this and developing a sort of a mobile ecosystem that actually takes into account the core principles of the science of behavior change into one platform that we've seen sort of transcend, that can have an impact that sort of transcends disorder, just transcends diagnosis, and really just thinks about behavior change and what we know about that cross-context, cross-population. So real opportunities here to drill, into the fundamental mechanisms of behavior change and leveraging technology in this space. And I think in the end, this will offer great value for our models of integrated care in general medical care settings. And related to this, of course, is the opportunity to have systems that learn. We talk about learning healthcare systems, but I think that this is not the traditional definition of how we talk about personalized medicine, but when you think about the science behind, how do you provide more potent tools for measuring, for providing interventions around substance use and health behavior broadly, we can have systems that adapt and learn and continually fed by the rigorous science that's being done in this space broadly with technologists, with behavioral scientists, and even more broadly with an interdisciplinary team. And so I think that there's opportunities for us to think about different models of evaluation. It's a different level of research, right? We can still have rigor around it, but really thinking about with real-world healthcare systems, how do we have ongoing evaluation and iteration in real-world implementation efforts based on data? What works, what doesn't work, refine, iterate, and evaluate. And so one example of opportunity in this space might be around a prescription model, right? So this isn't something that's been tested that extensively, but the idea that just like a physician provides a script for some medication, maybe there's an opportunity to test a model where you provide a script for use of a technology system based on someone's needs and values and goals. And this could be integrated into a healthcare system, but it doesn't have to be, right? So so we work with a lot of healthcare systems where I think sometimes we make the assumption that all the data that we collect on our mobile phones or from the sensors we wear or from the answers we give to prompts on our mobile devices need to go back to our clinician. And what we find is that so many clinicians don't want that. It's not that they're not valuing their patient, but one, it's not always actionable data. It's just sort of this, volume of data, unsolicited data, which often isn't actionable, but also can increase the burden and the liability on the clinician. And that's not what we're trying to do here. We're trying to add value and have some resource that can help all the different stakeholders, including clinicians, do their jobs better, right? And so there are opportunities for us to think about how can we offer these tools in a way that really brings value to the end user, and sometimes that's enough. Sometimes having that as a resource, another tool that's available to the patient or to the individual, can bring great value to the patient, but also improve the outcomes, the clinical outcomes that a healthcare system is trying to achieve. That's not to say that there can't be some select reporting back to a clinical system, and there are some pieces of information that could be very valuable from remote data capture to a clinical system. But I think we have to be very balanced in the way we think about what adds value and what may not, and may actually add burden. So I think lots of opportunities in the healthcare system space, but also tremendous opportunities outside of healthcare systems. Right? What about recruiting, entirely online, providing interventions, data capture entirely online, thinking about ways we can reach that 90% of people who are diagnosable with a substance use or mental health problem outside of our healthcare systems, right? These folks have these tools. They use them for all kinds of things in their daily lives. Why can't we provide resources that allow greater choice and access and engagement for people in their health, and in a way that reduces stigma? We don't have to, they don't have to embrace a stigmatizing, I have diagnosis X or I have DSM-4 label whatever. Why? We can still provide resources to people that are based on science that can be offered within and outside of healthcare systems. And I think there it's an understudied area of research about how do we best do this around substance use and related health issues in direct-to-consumer kinds of approaches. Another question that intersects with this a bit is this idea of studying trajectories of consumer engagement, right? So often if you see a research protocol and there's a design where you say, okay, I have this 12-session intervention that I do, in a traditional clinician-delivered intervention. I'm going to take that, I'm going to translate it to a computer session, and I'm going to ask you to do it twice a week for X number of weeks at 30-minute sessions. And if you don't, you're non-compliant, right? You're non-compliant, you're non-adherent. And I don't think we know that that's the right way to use these tools. I don't think we need to lock people into these sort of predetermined models of like, this is the dose, this is the way you use it in a way that's optimal. I think that if indeed you're trying to change a behavior or a pattern of behavior that involves people learning new skills, building out new personal and social resources around behavior change, that you might try to change some behavioral repertoire of that person. And maybe when they do that, they don't need to constantly have to use this tool forever and ever with some frequency. But rather, maybe there's going to be, periods of time where strategically, and episodically, they might need to access it. Or, again, use different tools over time as their needs change, right? So I think this is a real opportunity for us in our research to understand the optimal strategies to actually trigger change and mechanisms of behavior change that can impact what we think about in terms of dose and frequency of utilization of these types of resources. Just a couple of other comments. There is an extraordinary opportunity for us to leverage social media data in this space. People push out so much information about themselves on so many social media platforms all the time, and there are really impressive analytic models that one can use to extract and then analyze and interpret these patterns of data that people produce on social media. Things that rely on approaches of machine learning and natural language processing where you can understand sentiment and sort of communications that people have online. There's image analysis. There's all kinds of really striking methods that with these enormous volumes of data that people produce that we can understand new patterns of risk and profiles of risk, but I think also understand new ways to provide intervention delivery to people with these large volumes of data. So we talk about big data. We talk about big data with EHR systems. But, we struggle with the quality of data and the standardization of data in EHR systems. I think that this is another type of big data, and our analytics in this space are increasingly sophisticated and offer a very exciting opportunity, I think, for us to learn much more at a population level about risk behavior, including substance use, but also inform intervention delivery at that level. So this is, I think, an area that we can think more creatively in our research, and also particularly for adolescents. We know kids, right? They live on social media. They often are engaging in multiple things concurrently, and as long as they're awake. And so, a real opportunity to think about, how do you reach out to kids in novel ways, and to address prevention as well as tools for behavior change among youth. NIDA has funded us to do a study that's entirely focused on prescription opioid abuse prevention among teenagers. All the kids that are working with us on developing this and all the kids that are recruited for the clinical trial of this are entirely recruited nationally online. The whole tool is delivered online, data collection is online, and it's all based on principles of social media and that kids use all the time, and we leverage that in the context of this system that's specifically built to prevent misuse of prescription opioids among kids. So I think there's a lot of opportunity to think more about youth and thinking about early intervention. Not to say we don't need to intervene with folks who have chronic substance involvement, but the early intervention piece with young people, I think there's great potential there, particularly with technology. And the last point on this slide is just to underscore the importance of partnerships. Right, in academia, we have the privilege of doing very rigorous research and in partnership with funders like NIDA. But I think that if we really want to scale up the translation of this into real-world impact, that we have the opportunity to partner with commercial partners, for example, in ways that they're doing what they do best. The science is feeding that, but then, the scientists aren't charged with, sort of solely charged with pushing that out in a way that's going to be sustainable and scalable, but having strategic partnerships with shared vision around this. I'll just stop here on this slide. This is the website for our Center for Technology and Behavioral Health. We, again, have a wonderful team of interdisciplinary researchers in this space, and the mission of the center is to use science to inform the development and the evaluation as well as the implementation of various technology-based therapeutic tools for substance use disorders and related issues. And there are lots of resources and projects and shared learning from this center that we would love to offer to the Clinical Trials Network. I mean, it's, we have lots of shared interests, and I think the benefit can be bidirectional. And so we would welcome you to explore the site. We'll have lots of additional resources we hope to share with the broader CTN community for folks who might be interested in this space. So I have to shamelessly plug our book. So we had this great group of experts in their field contribute chapters to this edited volume, and we were just really fortunate to get real leaders to write around the whole space of the state of the science of development and evaluation and implementation, as well as regulatory issues and future directions and opportunities for using technology for substance use and behavioral health broadly. So for folks interested in this space, there's a volume that's integrated on it that was just published recently by Oxford University Press, but also you can pull out individual chapters online if you have an interest in one of these broader sets of topics. So I will stop there. Thanks so much.
So I have a million questions, but for the sake of time and not...
Can you introduce yourself?
Yeah, sure. So Victor, I'm from the Small Business Program here at NIDA. So the one question I'm going to ask, so with the insurance companies now very slowly transitioning from the quality to the quality of care model versus pay for service model, what is the state of insurance companies in regards to therapeutic education systems? And if they're not all adopting this, what data do we need to get in order to convince these payers to come on board?
Yeah, it's a great question. So as you may know, that there aren't any active reimbursement codes for interactive self-directed self-management tools, self-monitoring tools right now. There are codes for telehealth and things like taking traditional models of clinician-patient interaction and offering that in a distance communication. Many states reimburse for that, but they don't reimburse for some of the things many of the things we're talking about here. And for a long time, and this is, I serve on the Office of National Coordinator Policy Committee, and that in part we talk about this topic. And for a long time there was a discussion about how should we talk to CMS, how should we think about new ways to reimburse for very specific types of tools. I see that the dialogue seems to have changed quite a bit, and I think part of it is related to your comment that, there are systems now that increasingly are incentivized to invest in things that benefit them and the patients down the line, with particularly in capitated payment models, right? So although there's a cost to adoption of an approach like this as part of your care delivery model, we see some first movers in the space doing this because then they realize the benefit down the line, including cost savings down the line, not only for behavioral health costs, but also medical costs. And I see there's growing interest among many stakeholder groups, healthcare systems, insurance companies, in moving into space. I think there's not always clarity on how to best do it, but I see less of the pay-for-service kind of, reimbursement code activation discussion and more for how do we think about systems of care that bring value and quality, but also cost savings down the line.
Lisa, this is Betty Tai. The question is that if somebody is interested for smaller scale practice group, is this expensive investment for them? They can see down the road it will be, cost saving, but the first down payment to get all these technology into the office, do you have study for, what would be the cost, and how do you recuperate all these costs down the years?
Typically, the cost of adoption is not very high because the cost of development of these tools, right? But that precedes the deployment piece. And when you deploy, the cost usually is bandwidth costs and some costs for upgrades and technical support and things like that. And so the cost typically isn't that high. Some people use like an annual site licensing fee. Some people based on a per user fee. I mean, this platform I mentioned to you that is entirely designed to, embrace sort of all of health and not just like these siloed issues. I mean, it's pennies per per person really when you think about bandwidth. It's not very costly. I think one of the challenges we see that's related to your question is people, small practices, for example, worried about what infrastructure and expertise do I need in-house to take this on, right? Do we have, do we need tech support, tech-savvy people here to help people when they encounter problems with their mobile devices, for example? And some people worry, right, about training or, what's the burden to my site? Do we need IT specialists and things? And I think that one, if the vendor deploys something in a way that, that minimizes that, I think that adds value, or that they take that on, that adds value. I think there's also an opportunity, I didn't mention this here, for some studies of this, like maybe to think about centralized technology support banks, right, where we have a centralized system that can help all these small, programs adopt and support these things and provide them with information about what do they need to know when they consent a patient, what are the issues about confidentiality and data protections, sort of some shared resources that people can tap into in adoption of this to facilitate that. A vendor could take that on, but it could be also something we study as part of changing up our healthcare service delivery model. Maybe this is a new part of the equation. Mobile support specialists, technology specialists that can help facilitate this in a scalable way.
Any other questions for the listeners in the cyberspace?
I think folks have to unmute with *6. Is that what we were told? *6
That's
to
correct.
unmute.
*6 will unmute, and then *6 will remute your line.
Thank you.
Lisa, that was a terrific presentation. TED Talk worthy. Thank you. I have a question about your work with ONC. Do they have any initiatives in this space being planned?
Well, there's a lot of talk about, meaningful use, and also how do we, so there's a lot of talk about EHRs and those kinds of issues. We talk a lot more about service delivery models and how can we embed these types of approaches in that. And most recently there's been a discussion around what are some terrific examples of systems that have adopted this and what have been the lessons learned in this space, and how can that translate into some recommendations or guidelines around this. And so it's a process, but there's interest. We don't have, right now, there's some products that have come out in the privacy security space that are very relevant, and including some recent ones that were released. But in our team, which is not the privacy security work group, but it's the one on sort of integrated integration of technology systems into providing meaningful use in healthcare service delivery, our group hasn't yet produced that document, but it's in the works. Okay.
Lisa, thank you again for a fabulous presentation. So I was curious, in your work, working with various models of integrating substance use care in primary care and with specialty care and things like that, have you run into issues with Title 42 CFR and that's sort of just cited as an obstacle for this kind of collaboration and communication?
Yeah, so that surely has been a topic of discussion about the different levels of protection afforded to mental health and substance use data that sometimes prevent it from being fully integrated into other medical data in EHRs. And I know of several groups that have some workarounds around this, but I think that there are two things. One is that we need to understand that more and think about sort of how to better do that. We have a colleague at our center who I believe has started to join the healthcare data science work task force, who has expertise in this space, and we hope, Carmen and I were speaking earlier about upcoming speakers for this webinar series, and we hope that he will be upcoming speaker on our list to talk about this very issue, among others, with data protections and data integration. What we also find, though, is in a lot of the work that we've been doing that I've touched on today, not everybody wants to include all this in the EHR. I mean, not that we don't need to know about sort of, problematic substance use and document, what's offered in response to that. But in terms of some of the data that are tracked in these systems, we find that there can be value even, again, outside of pushing everything into the EHR. But also, if there are pieces of data that you want to pull into EHRs, you can have APIs that sort of intersect with these types of tools. Even though it's not full integration to Epic or something like that, you can have an interface where you pull, like an API where you can pull whatever data you want from these systems into the EHR. Some people are starting to do that, but I want to underscore the value of in the absence of working out all of those challenges, there are still opportunities to move into the space and deploy these types of resources in a way that can add value without entirely integrating every single data point into the EHR. That's my opinion based on our work in this space. Okay.
I think I may didn't read the slides well. Could you comment on how many subjects were in the CTNTS study?
Yeah, it was, I don't know the exact number. Does someone in this room know it? Or perhaps someone from that team is on the line and could say it. But it was a 10-site study. It was 500 and some, 528.
528,
yeah. Okay.
Because I think, sometimes the number will give you the sense of power and the confidence.
Yeah.
So I think, that's a good study. Thank you.
Yeah, great. Thanks.
Hi, this is Carol. Can you tell me on a prevention study that you're doing, what is the number that you're recruiting? That you're doing that all online?
Yeah, all online. It's over 400 kids. Yeah, it's a controlled trial, and we've been working with youth to develop the whole tool, of course. I mean, working with your end-user audience and development is really key. And there's a growing literature on how perceptions of risk of prescription drugs differs in some systematic ways from perceptions of risk from sort of illicit drugs. And there are different, like your parents don't care as much if you get caught with these things, or there's a perception that, a doctor somewhere has prescribed these, so how risky could they be? You're not sort of buying them from a drug dealer. So there's a lot of, there's a growing prevention science literature that shows there are different patterns of understanding of these substances relative to others. So the idea is to capitalize on that growing literature with young people, and with young people create, basically it's almost like a blog interface. It uses a lot of principles of social media to communicate these things in interactive ways to kids, and the whole intent is to push it out that way as well. But right now it's in an evaluation stage. So with 12 to 18-year-olds, yeah.
Great presentation, Lisa. I have a quick question. So the effects of TS in the CTN study were not durable past active treatment period. So I'm wondering, what is your sense of how to fortify the effect that is evident in TS and other systems to make them more durable during follow-up periods?
That's a great question. I think when you think about any treatment and, sort of the post-treatment effects, what are the resources and tools you offer after that to sustain support? I think that, boy, there's lots of opportunities with technology. Again, I think you can have adaptive tools over time. What people need, when they start treatment may be very different than what they need when they're years into recovery, for example. And so I think that we need to better understand that trajectory and how to flexibly change up what we offer in response to that. But the other piece, again, to underscore something I mentioned earlier, I think that we need to think a lot more about social support systems, right? Not everything has to rely on our traditional treatment model, but there are really powerful social support systems that we can offer to people in maintaining recovery or even helping to start that process, right? And, even some important research focused on things like network therapy, where you have significant others enter treatment and support someone in a treatment attempt in a very traditional model where they come to the program with some. Why don't we mimic that in a way where we have some data sharing about people's successes in treatment with a virtual support network of people of their choosing, right, to support them in that treatment attempt and beyond, and to sustain some of these effects and perhaps increase their potency. There are lots of questions around that remain understudied, I think. Thanks, Udi.
Lisa, you cited a study or showed a study where they found 84% retention with the mobile intervention compared to 56% with standard treatment. Is there any qualitative information, or what's your sense of why that was? Was it likability of the intervention, additional skills development, logistical factors?
That's a great question. The paper from that study is it may have just come out. It's probably published any day if it hasn't come out already. It includes a very rich set of qualitative data, actually, and what we find is that yes, there's a lot of likability, and people really liked the resource right there with them all the time, not just when they went to the treatment program. That was a big part of it. But I think a big part of it were the interactive tools. So, for example, there's a whole self-management planning routine where you can strategize for yourself around what can you do to be successful today and not using, for example. I mean, lots of tools that are really relevant in the moment, but also a lot of, I think the skills training piece is part of it. How do you effectively refuse a drug offer? Or, those kinds of things people say they really value, and they practice that and they try these things out. So, but as soon as that, I can send you that paper as well, and there's a real rich piece to that. Honoria Guarino is the first author on that.
Thanks.
Sure.
Lisa, thank you so much for this wonderful presentation. I will give another chance for those who are listening in on the web. You have any question, comment, please share with us. If not, thank you all very much. And also, Lisa, hope to hear from you again. And we will resume our data science series in another 2 to 4 weeks. 4 weeks. And but we will have a data science work group call in between. Friday, this coming Friday. Look forward to speaking to you all again. Thank you. Bye-bye.
Thank you.